Flinders Northern Territory and all our presenters this evening would like to acknowledge and pay respect to the past, present, future custodians of the land and the elders of this nation, and the continuation of our culture, spiritual and educational practices of our Aboriginal and Torres Strait Islander peoples. In particular, we'd like to acknowledge the peoples of the Larrakia Nations, which is the country from where Marco and I are sitting here in Darwin at the moment, although Marco usually lives in Nhulunbuy on Yolngu country, particularly the land of the Gumatj and the Rirratingal clans. Another presenter, Sophie, is in Gumbalanya at the moment, the lands of the Mendri, Gadjudu, Era, Wuninga, Amaduk, and other Kunjwinkle speaking clans. And I'm sure Sophie knows how to pronounce some of those much better than I do at the moment. We're also joined by Jasmine Banner, who's in Catherine on Jowan, Dogaman and Waterman country. And Catherine Gargan, who recognises the following nations from northeast Victoria, where she's currently located, but has really close connections to living and working in the Northern Territory. And she's on the Yetmatang, Durhora Waywuru and Durdorora Dargul people's lands. And again, I'm sure she's much better at pronouncing those than I am. I'd also like to acknowledge any Aboriginal and Torres Strait Islander people who are joining us this evening and the lands from all of the other nations where you might be listening in this evening. For those of you who don't know me, my name's Dr. Olivia O'Donoghue. I'm a general practitioner living and working in Darwin at the moment, also the medical director for the Regional Training Hub. I'm very passionate about the topic we're talking about this evening, having trained as a rural generalist myself, particularly in the field of Aboriginal and Torres Strait Islander health, and spent much of my training in northeast Arnhem Land. So I'm looking forward to introducing you to some of our other fellow rural generalists, new and old from around the country, from around the Northern Territory, I should say. Today, as I mentioned, very briefly, but I'll give them a little bit more of an introduction now, we're joined by Associate Professor Marco Brienko, who is the Director of the Northern Territory Rural Generalist Coordination Unit, and on leave as Director of Medical Services, Education and Training from Gove District Hospital in Nhulunbuy, where he practices as a rural generalist surgeon and all-rounder, I believe. Dr. Sophie Scrimgeour, who's a current rural generalist trainee through the ACROM program, living and working in Gumbalanya. Dr. Jasmine Banner, who's a GP obstetrician, living and working at Catherine District Hospital, where she's also the clinical lead of the Catherine District Hospital Maternity Unit. And finally, Dr. Catherine Gargan, who is a general practitioner and working with top-end health services in the population and primary healthcare. They're going to give themselves much better introductions than I have just now and tell us all about their training journey. But first, I'm going to stop sharing my screen. I'm going to hand over to Associate Professor Marco, and he's going to tell us all about the wonderful opportunities of being a rural generalist and what a rural generalist is in the context of living and working in the Northern Territory. Thank you, Marco.
All right, thank you, Olivia, for the introduction. I think that was a very, very good introduction. So I don't need to introduce myself anymore. So as Olivia said, I'm Marco Briseno. I'm a rural generalist by trade. I'm a FACROM, so fellow of the Australian College of Rural and Remote Medicine. And I'm the current director of the NT Rural Generalist Pathway. And I still practice clinically in the hospital in Gove as a rural generalist. Surgery is my advanced skill. I want to echo Olivia's word about acknowledging the country and where we meet today and paying our respects to the traditional custodians and their leaders, past, present, and emerging. And I guess I'll provide a quick overview, and one quick question that keep coming is, well, what is a rural generalist and who is a rural generalist, and what's the difference between that and a GP and a rural GP or a district medical officer, etc. And then I'll talk a little bit more about the NT specific rural generalist pathway and provide some of the national context as to where we are. So who is a rural generalist, and what's a rural generalist? So in 2017, during the third World Summit of Rural Generalism, in Cairns, there was a consensus, and the over 200 delegates from about 23 different countries agree on a definition. And then that definition was further adapted to the NT context by both colleges with what is known as the Collinggrove Agreement. And it is a very wordy definition and sometimes difficult to quickly explain, but basically, a rural generalist is a doctor who is trained to provide care to a community, and that the care is adapted to the community needs. And the care sits in primary care, so it's a strong primary care provision of comprehensive primary care, but also has responsibilities in the delivery of acute or emergency care, and also extended skills in different specialties of medicine, and has also a very strong component of public health or population health. And they make a very sort of important accent about the fact that it's part of a rural healthcare team. So rural generalists work in partnership with remote area nurses and with allied health professionals and with Aboriginal health practitioners in the delivery of comprehensive care among all these domains. So on that definition, we probably will part a little bit from the traditional understanding that a rural generalist is based in a hospital and is doing obstetrics or is doing anesthetics. The reality is, yes, there are some rural generalists that are based in hospitals or that have part of their practice in hospitals, and that's very much the traditional definition based on the Queensland model. But in the territory, we only have 3, maybe 4 hospitals that will host rural generalists, and the majority of our rural generalists are actually working in the community setting, in the primary healthcare space, delivering comprehensive primary care, delivering some emergency care, and delivering extended skills, not necessarily in the historic traditional procedural areas, but more in the Aboriginal and Torres Strait Islander health space, in the mental health space, in the palliative care space, and in other less traditional areas. So then, just provide a bit of national context. A few years ago, the Commonwealth Department of Health acknowledged the need to recognize rural health as a different area of health, and there was the appointment of a rural health commissioner. And luckily for us, that paved the way for a better understanding and better investment in rural health. And one of the main gains from that was the enough push to create a national rural generalist pathway, to make sure that there is a clear training pathway for doctors that want to become rural generalists, but also there are clear pathways for employment, clear pathways for models of care that will cater for that, and raise the profile of rural generalism as a recognized specialty. There's been a submission by both colleges to the Australian Medical Council to recognize rural generalism as a subset or a subspecialty of general practice, which will then again pave the way for better credentialing, different employment models, and make sure that rural generalists can offer fully everything that we can bring to the table. During this investment of the creation of the National Rural Generalist Pathway, each jurisdiction was given an opportunity to apply for funding, and that's where the NT Rural Generalist Coordination Unit was created. I think later on in the presentation, I'll be able to probably expand a little bit more on the rural generalist training pathway in the NT, but I just wanted to share a little bit of my own story, how I became a rural generalist and what's been my involvement in expanding training opportunities for other doctors that want to follow a similar career. I'm a Venezuelan graduate. I went to medical school in Caracas and I finished my medical degree in 2000. And during my intern year, I did a stint in the Amazon and had exposure to indigenous health, and really was blown away by that prospect. Unfortunately, that was only a short-lived experience that left a very deep print on me, and I went back to the city to train in surgical specialties and emergency. I spent another year there in the rural areas of Venezuela after I qualified, and then I decided to moved to the UK, where I became a surgical trainee, and I was a surgical registrar in England and in Wales for 4 years, and I gained my qualification as a member of the College of Surgeons of England. And then I was sort of pursuing a career in the surgical field, in not knowing that there was an opportunity to become a rural generalist. And I was moving to Spain to finish my advanced training in orthopedics, where by chance I ended up choosing to come to Australia for 6-month adventure. And that 6-month adventure happened to be in Nhulunbuy, in Arnhem Land. And that 6-month adventure is turned into a 12 years and ongoing experience. Halfway through that adventure, I decided to formalize my career as a rural generalist, and I joined ACROM, and I got my qualification in 2013 as a rural generalist surgeon. And I've been working in Arnhem Land in a variety of roles during that period of time, in private practice, in the Aboriginal medical control sector, in the NT government-run primary healthcare clinics, and in the hospital. And also have worked with Flinders University as a lecturer and senior lecturer in part of the medical program. And I've been very actively involved with NTGP and in the delivery of GP training. 5 years ago now, I turned to the dark side of medical administration, and I became the director of medical services of the hospital, and a year later of the regional director of medical services, to also include primary healthcare. And I have enjoyed a very, very exciting career where I'm a clinician, I'm an educator, and I'm an administrator, and I'm a clinical leader in trying to influence policy and ensure that we raise the profile of rural journalism, and also that we make sure that we create pathways for medical students. And Sophie can provide some of those examples about starting in third year or fourth year of medical school, rotating through a place like Nhulunbuy, and then offering opportunities to interns and then pre-vocational doctors. And we have a regional registrar training program, and I've been very, very strong in advocating and creating some of those spaces. And that had paid off for us. I mean, in Nhulunbuy, from having only a handful of doctors when Olivia and I used to work back there, there were probably 7 or 8 of us, and now there are about 45 doctors in East Arnhem. And from having only a couple of people with fellowships, now we have about 20 people with fellowship of ACROM, RSCGP, or both. People with public health qualifications, people with careers that have gone beyond what we originally intended, not only service delivery, but also being involved actively in education, in academia, in management, in policy, etc. And then this year, I decided to take the leading role in the establishment of a formal pathway for rural journalist training in the NT. We do have a very, very strong pathway in the NT to train rural journalists, and many people in the panel are living examples of that, me included. But this is an opportunity for us to formalize, to strengthen, and to expand some of that. That's more or less my story, and a bit of an overview of what rural journalism is all about. It's a career that offers you the opportunity to reinvent yourself, to apply your core knowledge and skills, and to adapt those to the needs of your community. And to do that in a way that is contemporary, that is adhering to evidence and to contemporary practice, but at the same time that is adapted to the location in where you're practicing, and that is respectful and inclusive of the choices of the population you service. So it is a very, very exciting time. There is no way to learn that in a book. What we do is take the evidence created anywhere else in the world and try to apply it to the best of our abilities into the context in where we work, and trying to at the same time influence policy to make sure that policy recognizes and acknowledge that in the territory, 40% of the population does not live in Darwin or Alice Springs and need to access care in a way that is aligned to their belief and preferences, that is aligned to the resources that are available on the ground, but that we need to offer the best possible care we can closer to home. And that's more or less what we're trying to do at a larger scale. I'll be very happy to sort of expand on that and to take questions and open up the discussion. And I can expand a little bit more as to what the coordination unit is doing in the NT later on. So I'll hand back to you, Olivia.
We're very excited to hear about what is next for rural generalism training and the supported pathways in the NT. So we're looking forward to that discussion a bit later. You've reminded me of lots of memories of living and working in Arnhem Land way back when you said. Yeah, it's something that's very, very close to my heart and something that I miss immensely, I must admit. And working in our rural and remote communities and close with our Aboriginal and Torres Strait Islander populations is something that is dear to many of our GPs and doctors and rural generalists living and working right across the Northern Territory. So thank you for that, and thank you for sharing a bit about your journey from the Amazon to Yolngu country and how that came about. It's so interesting to hear everybody's stories. I think before we get into too many questions, we might hear some more stories from some of our other presenters. And I'm going to hand over to Sophie to talk to us about her training experience so far in the Territory and living and working in one of our quite remote communities. Thanks, Sophie.
Thanks, Olivia. Thanks for the intro. And yeah, thanks, Marco, for sort of offering the stories, I guess, from the other end of the spectrum. I'll just share my screen. But so I, as Marco said, landed in Gove 8 years ago now as a third-year medical student, and it sounds corny in current company, I guess, but pretty inspired by what I saw there. And I think since then have been on a path that I started picturing for myself back then as a third-year student, and now I'm PGY 6, and yeah, I guess I'm becoming one of those doctors that says, oh, way back when. And yeah, it's the time does fly up here, and I've been in the Territory pretty much since then, with stints in other places, but based in the Territory. And I really feel honestly lucky to have had the experiences that I've had, the broad array of sort of work and life experiences that you get up here. I'm sure I'm preaching to the converted. Everyone's already up here and is up here for a good reason, but even after all these years I still feel really lucky. So on that, I guess just, you know, thanking and after Olivia said that I would be able to pronounce it better than her, I'm going to embarrass myself now. The Majolungun clan, that was probably the worst yet, in Gumbalanya, who are the traditional owners of Gumbalanya, and there's many other clans for the surrounding areas. And Gunwinyu is the main language here, which there's nothing that's made me feel dumber in my life than trying to learn Gunwinyu. I'm really struggling with it, but it's an amazing language and beautiful to hear. And completely different to Yolngu Matha. I think I thought there'd be some similarities, but these people are amazing. A lot of them sort of go between and speak multiple languages, and completely different from the next region. So yeah, I've been in Gumbalanya, or Ompeli as it used to be known, since the start of the year. And it's not that remote, particularly in the dry. Like, we can drive to Darwin in 3.5 hours, which yeah, makes it pretty easy. And then in the wet, Cahill's Crossing goes up and it becomes waterlocked. So at which time it's a flight in and out to Jabberoo or to Gut or to Darwin, and it becomes a bit more isolated. But all the waterfalls start filling and the surrounds become even more exciting than they are in the dry. So yeah, and it's about 1,500 people, including some of the outstations that are around, that the health clinic that I'm working for also services. So like many of the remote community services, sort of not just the core population in town, but does flights and drives out to outstations and takes calls from those. So it's a really exciting, diverse job with a bit of emergency, but mainly core primary care work, which I really enjoy. And I guess going back to my path sort of to here so far, I was a Flinders medical school student and took the opportunity to come up to the Territory in third year, and as I'm sure many people can to attest to, sort of the plans never go exactly as envisaged. And I think I was meant to be in Alice Springs for 6 months, and I got there and they said, there's 6 students, not 4. Where are you going to send you? So I got sent to Tennant Creek for a couple of months, working in the GP and ED there, and then to Nhulunbuy, was as I think one of the first 3rd year students, and just really thought, sort of watching the rural generalists there who did a bit of the primary care. So I think at that point nearly everyone was doing primary care and the hospital work, and just watching that rapport, I guess, compared to what I'd seen particularly in Adelaide hospitals, but even in places like Alice Springs, where it's really quite distinct, the hospital doctors and the primary care doctors. Just watching like the bit of language the doctors had, and just that kind of calm that you see come over the patients when they see a doctor that they've seen in their own context, in their own world, was, really nice. And I think that stayed with me, even sort of going to Darwin afterwards and doing placements in Darwin, Adelaide, and overseas for the 4th year. I think it was that kind of just those moments that watching how the generalists were able to interact, that stayed with me and made me think as I went through. I still wasn't entirely sure, but I really liked all my rotations in internship and residency, and thought, I think generalism or GP is what is going to keep me excited throughout my life. So I did my internship and residency in Darwin, and amongst all the basic internship things, also in residency did PEDS and ONG. And I guess here I've just put some of the sort of the little certificates and stuff that I've done along the way for anyone looking at doing different pathways. I think everyone's different, but I find that I learn a lot better with a sort of maybe a stick behind me of an exam coming up or assessments, and I've really appreciated doing these little bits and pieces along the way to kind of keep me studying, but also I think it fosters a bit of a better, it can often allow for a better sort of learning relationship with your seniors if you're doing a particular course and you've got a logbook or whatnot to sign off. It's a good way to keep learning. And then, as an RMO, went to Catherine Hospital as my in 2nd year, and really, really enjoyed that, and the working with the physicians as well as the GPs there, and just that model of care. And then in my registrar training, as you can see there, I've jumped around probably way too much, and I think that this is testament to just perhaps how indecisive, but how excited I kind of get about all the different aspects that you want to learn. And I think also my I guess perhaps naively I was quite surprised about how hard core GP was. I had this overwhelming sense that I needed to go and get more and more skills after I got into that GP room, and wanted to kind of get a little bit of everything. So it's resulted in me moving around every 6 months, and often even in that 6 months doing 2 jobs, which I think I got to the middle of last year and realised that I really had missed out on the beauty that you get when you are in one place doing one job for a year doing core GP work. So that's why I decided to do a AST in population health to sort of expand my public health skills, which I'd sort of done a little bit in my past degree, but I also just wanted to do another year of getting to know one community and the patients and all the intricacies and the things that come out of that. And I'm really glad I have. So I've been in Gumbulanya, like I said, from the start of the year, and have really enjoyed that. And I guess just going back, like this wasn't officially part of my training, but I think it could be if I wanted, doing the Diploma of Tropical Medicine at the London School, which I was really lucky to do last year before London shut down. And I think that really brought to my attention, talking to the best part of that. It was an amazing 3 months. I highly recommend it. But you get to meet an amazing array of excited doctors from around the world that are doing cool stuff. And I think that really brought home to me, though, as well, how lucky I am. And at the end of that, I thought I might sort of start getting itchy feet and think I want to go off and do MSF and, stuff around the world straight from there. And, I'm not saying that stuff all looks amazing, but I think talking to different people about the foibles and the the various challenges that people face everywhere, it made me really excited and happy to be returning to the Territory and working in the context that we work in, getting to see the array of stuff that we get to see as GPs here, particularly remote GPs, and working in our own country within these amazing diverse cultures. So yeah, that was a really nice learning curve for me in terms of the generalism pathway. So I've touched on a lot of these things already, but in terms of what gets me excited about generalism, it's I guess just something that I haven't listed here, but sort of on this panel was brought to my attention, is the amazing people that you get to work with and the like-minded people that are drawn, I think, to rural generalism, such that you just get to work with, I think, people that you generally like and that you kind of identify with, and you enjoy their company. And I think that that's a huge part of job satisfaction and enjoyment of your life and your work. That relationships and the trust that you get to develop with the patients. It sounds corny as well. It's hard to avoid the platitudes and a thing like this, but it feels quite real. I think you closing a door a lot of the time and you're there just with this person. There's less of the perhaps bravado that I think I found in the hospital of these big shows and with a ward round of 12 people and, you know, one patient looking up. And I think just that person to person relationship that you get with your patients is pretty cool, and we're pretty lucky. With the workflows, I think, again, compared to the hospital, I found there's less ability to say no, like, you know, that's not cardiology, that's respiratory, and that passing the buck between things. It's that you have to do a bit of everything, and everyone does. They take on what they need to and what they can. The teamwork, and particularly in the remote settings, like it is between the Aboriginal health workers, the community workers, the nurses, every patient's a team effort, and that's really nice. I think it's a really nice way of working. The variety of stuff you get to see, the ability to work on the upstream issues, the public health kind of stuff, as well as the downstream stuff and the emergency stuff that comes in. You know, you do get that adrenaline type stuff and get to treat a patient and make them better, and then in that acute setting that we all find bizarrely satisfying, but then get to see them when they're better and in the context of their actual life. So I think all of these things is why I chose rural generalism. And I guess coming back to the cons, like it's all not, you know, sunshine and lollipops, and often it's related to the pros. I think the teamwork, as much as it is honestly one of the best parts, remote practice particularly, it attracts a very passionate group of people that are isolated perhaps from their usual support networks, and they've got a broad church of views. So I think often, as I'm sure other people can attest to, there is conflict in remote clinics between staff, and that can be sort of, not very nice to walk into every day. And that's, I think, ebbs and flows, and it comes and goes, but it's part and parcel. And doesn't always need to be like that, but you just need to know that I guess that it's a common story, and not to get down about it yourself, because I think that's a potential trap, particularly as a junior doctor, just watching it, just sort of being amongst that. The sense of community also leads to visibility, I guess. So it's lovely being part of a small community, but you are seen at the shop, you're asked questions at the, you know, when you walk down the street to chase a dog, and you have to go on Facebook Live on the Goombaland notice board like I have today and multiple times in previous weeks, which I hate doing. And it's part of being a visible doctor in a small town, and having people get to know you, I guess, in the context of your life and the clinic. And I think something that has taken me a while to figure out, but just the richness that comes with actually understanding a community and getting those community bonds, which does just take time. And it's the amount of people that these communities have seen churn through, come in and out. I think just watching people stay around is what builds the trust. And I think that takes time, obviously. And when you want to get variety of experiences, and when you're a bit indecisive like me, that can be tough, but to balance that out. But this is the longest I've been in a community, and I'm really enjoying the richness that comes from that. But obviously, it's just a decision you've got to make. So back to the pros, making myself look like a wild hunter. I'm definitely not. I'm a total wuss when it comes to this, but just, I guess this is just testament to being welcomed into amazingly beautiful country, with generous people that are willing to come and help you, shoot a buffalo, and talk. Well, sorry, I didn't shoot the buffalo. That is completely false advertising. But just, talk you through their way of life and welcome you in, and fishing at a billabong near one of the outstations. And I didn't catch that file snake, but someone I was with did, and makes me look like I'm tougher than I am. But yeah, it's pretty lovely. And just really honestly, like, I know, you're not going to have a territory presentation without some pretty landscape photos, but I think this country is just beyond stunningly beautiful, and I feel really lucky to be in it every day, and I guess that's part of what makes us so lucky. Thanks, Olivia. I'll pass it back to you.
Thank you very much, Sophie. I think anybody who's ever been out to Goombalanya and goes through Cahill's Crossing by car and then comes out on that beautiful open floodlands on the other side of the escarpment, is really listening to you right now going, that country's pretty special. We have lots of really wonderful country around the Northern Territory. Thank you very much for sharing your story. I was just wondering if you had some reflections on just how much those early experiences in the Territory really cemented for you the choice of where you've ended up in terms of training and locations for all of your training.
So absolutely it has, it was the genesis of it, but I think, I guess, just sort of presenting the opposite side of things. I think as a medical student, I was like, I just want to be like Marco and Greer and be a kick-ass rural hospital doctor. But I think, as I went through, and you just sort of get to know what really gets you excited. And I think, as much as I like, hats off, I find that stuff is sort of impressive and exciting. It's just, it wasn't what really sort of, brought up the passion in me. And I think, sort of, I thought of all the logistics around having to live in a place that a certain size of a town that allows for GP obstetrics or GP anaesthetics, and sort of deviated from that pathway a bit in terms of deciding I wanted to learn how to be a good GP in that one-on-one setting. So, I don't know what the definition of a GP versus a rural generalism is, but a rural generalist is. We should, after Marco's great presentation, and I know what you're saying in terms of that acute stuff as well. But I think it's the core GP stuff that gets me excited. So that's not really answering your question. It's saying, I think absolutely it was particularly my third year experience that has informed my decisions going ahead. But I guess it's my further training that sort of added a bit more nuance and changed my thinking, which was pretty gung-ho at that time, kind of wanting to be just like those guys.
And Sophie, can I ask once you finish training, what your dream job or what your sort of end goal will be? Do you know that yet?
You can, Jasmine, and I'm not going to be able to give you a good answer. Yeah, I think working in a place like Goombalanya, in a site, I think I've really enjoyed the size here and the sort of mixture of acute stuff you get, as well as the patient population. But also I think perhaps doing clinical work 4 days a week and something else a day a week, or face-to-face clinical work, like, I really enjoy it, and I find it really, tiring, as everyone does. And I think keeping that diversity would be good. So doing either research or teaching as well the other day of the week. But yeah, being a stock standard remote GP, I think, gets me pretty excited. But I haven't entirely figured it out yet. If you have any ideas, let me know.
I don't think there's anything stock or standard about being a remote GP, especially in the context of the Northern Territory and other lots of really remote places all around the world. I think you yourself have probably sold what rural generalism is, because what you're doing out there is not your standard office-based general practice work that you might find in an urban setting. And the variety of skills that you've accrued to go out there is probably well above and beyond another clinician at the same level chronologically as you in their career who has made a decision to go out to a remote community. Just the palliative care, the language skills, the women's health certificates, the family planning certificates, all of those things I would imagine you're using on a daily, if not weekly basis in your community, and the variety of practice and the skill set that you've accrued to do that is testament that you're living the rural generalist career, I think.
Yeah, thanks, the rural generalism dream. Yeah. And I guess we're so lucky to be able to just do a little bit of this and a little bit of that, and I guess it's great for indecisive people such as me that like a lot of different things.
Yes, and you might have needed some sticks to accrue all of those extra qualifications, but I'm certain that you've spoken about many more carrots today to actually get you to where you are. Yeah, and all of us want to be kick-ass doctors like yourself and Marco and Greer, and I'm sure the next person I'm going to introduce you all to, Dr. Jasmine Banner. Let's hear a bit about your story and your journey and what you're doing, which is quite different to Sophie. Thanks, Jasmine.
Yeah, thank you, Olivia. Thanks for having me talk today on this panel with some very inspirational people, and pretty humbled to be in this company. I unfortunately don't have any pretty slides of wonderful NT landscape, and I wish I had more time to prepare. That's just me being disorganised, because I have some amazing pictures too, and some pretty special experiences living and working up here in the Katherine region. So you'll have to bear with me in my bleak office background, and I'm actually on call for obstetrics tonight because I also didn't work out my roster, so hopefully we won't be interrupted. So a bit about my journey. I went to medical school in Adelaide and grew up in Adelaide, and always knew that Adelaide winter was too cold for me, but had no real connection to the Territory apart from the fact that my parents used to live up here before I was born. So I guess there was always that unconscious curiosity. And then was lucky enough to have some rural medicine experiences in medical school in rural South Australia. One of which was to go on a field trip to Mutijula community near Uluru and meet some of the elders there and the custodians of that land. And that was, I think, one of the sort of formative experiences of my medical school experience, and was sort of the first taste of the Territory for me as well, and was pretty special. And then figured out that I wanted to get up to the Northern Territory to work, and to do that needed to have a medical school placement in the Territory to sort of elbow some of the Flinders students out of the way. So I managed to get myself up to Katherine for 6 weeks, doing a mental health placement in my final year of medical school. And so that was my first introduction to the Katherine region, and really enjoyed that, and got to go on some bush trips, and was shown around by the lovely ladies who've been living here for a long time and delivering outreach mental health. And then, moved to Darwin for internship. Rural generalism was always sort of something that Queensland people talked about, but no one really in Adelaide or the Northern Territory talked about as such. And I did have some friends who went to Queensland and sort of got scooped along this pathway of rural generalism, and I was always quite curious about what the difference was and what, you know, the pathway that I saw myself going on and what they were doing, how that differed. And I sort of, I guess the doctor that I always wanted to be was a rural doctor and a rural generalist or rural GP. And so despite no clear pathway, that was sort of always, I guess, the end goal for me. And I was lucky enough that I had often had the opportunities quite easily accessible living and working in the NT and in Darwin to get myself those qualifications and along that sort of pathway. So I did my internship and junior doctor years in Darwin, which involved, again, a stint in Katherine Hospital, a GP term at Worley in Katherine. And so I kept coming back to the region, sometimes by accident. And then sort of the third or fourth time I came here, I decided that I really enjoyed living here and enjoyed the area and the people. And some of that was bred by familiarity of just coming back. And, you know, rural and remote people are, as Sophie sort of touched on too, are super generous and super, I guess, welcoming when they do see familiar faces coming back again. So some of that appreciation, I guess, made me realise that just that continuity of seeing people come back and not just flying in and out and being a sort of flash in the pan doctor, it was really appreciated by the local people. So I'm sure that was part of the reason why I kept coming back as well. So I joined the ACRM training pathway in second or third year out, and wasn't really sure what advanced skill I wanted to do, but ended up in an emergency term around when I had to decide and was really enjoying it. So I stayed and did that, and was lucky enough to do some of my emergency time in Alice Springs and Darwin. And so did my ED diploma in Alice and Darwin, and really enjoyed emergency, and I knew that it would always be useful as a rural doctor to have those extra skills. A lot of my mentors and sort of the old school rural GPs that that supervised or mentored me as students, I guess, just gained those skills with time and experience. But as a junior and quite young doctor, I felt that I sort of needed that piece of paper and as Sophie alluded to, the stick to sort of gain those skills and to give me the confidence to ask people to supervise me and to teach me. So that really helped my pathway and my confidence as well in that area. And then went on to do my GP terms, mostly in the Katherine region. So I was lucky enough to do terms with most of the GP practices around here. So Worley, the Aboriginal Medical Service based in town, Gorge Health, the private GP in town, always working part-time in Katherine Hospital Emergency to keep those skills up, and then a year with Sunrise, which was remote outreach GP to the communities to the east of Katherine, and that remote GP experience was amazing, and yeah, some of my favourite times of being a doctor, I suppose. It was really special to be welcomed to those communities, to be taken out and to be living there at least part-time. So that was really cool. And then I fell over with ACRM and decided that I hadn't done enough study, and always really liked women's health, and so decided to go back and do my advanced diploma of ONG. And so went back to Darwin to do that for 18 months before coming back to Katherine. And for the last few years have, decided that I really wanted to come back to Katherine, and that would be a useful skill to have down here, to be working here in maternity. And so yeah, I finished that about a year ago and have been here mostly working in maternity since then. And really excitingly, I've sort of been doing full-time maternity for a while, so feel my GP and ED skills slipping a little bit, but been doing those part-time whenever I can. and consolidated my maternity skills, which has been great. But I guess my sort of dream for this job and for the Katherine Region Maternity Unit is to build a really great team of GP obstetricians, which hasn't been the case here for a little while, and to start some outreach and see women in their own environments, in their own clinics on their land, which has just been happening in the last few months. So that's really exciting for me and for us here. And it's been great to get back out to doing some remote work, and especially with this, extra skills of women's health, to be able to provide that on people's land has been, really cool. So I guess that's where I am now in my journey. Sophie has said a lot of what I was thinking and what I wanted to say very eloquently, so I won't repeat everything, but I do agree of the main pros and cons of living remotely, and just the broad scope of what you feel like you should be able to do when you live and work in really isolated areas, and you can't be good at everything and you can't have skills in everything, despite doing lots of bits and pieces of things and certificates. So you just do the best that you can, and if you're not there doing it, no one else is. So I guess that sort of has provided me a little bit of comfort when I'm self-doubting and wondering whether I do have the experience and the appropriate skills to be out here. But yeah, we had some pretty inspiring mentors who have been doing this for a long time and sort of showing the way of how to do it, and it's pretty exciting to have a bit of a pathway to formalise how to get to some places. But I guess, as we've all seen, we've all got very different pathways to get to similar spots, but we're also doing lots of different things. So it is very customizable to where you're working and who you're working with and what you're doing. Yeah, that's my story.
Thank you so much, Jasmine. Lots of similarities and differences from your experience and your journey to both Marco and Sophie, but still ending up in a place where you're really passionate and delivering well-needed health services to the community. I have a question. You said you decided to go back and do the women's health certificate and the advanced obstetric and gynecology diploma, because you've always had a passion for women's health and stuff as well. But that long-term connection you had with Katherine, I'm just wondering whether the ongoing, need and succession planning and delivery of women's health service, particularly obstetric services to the Katherine community, did that have any bearing on your decision to go down the pathway of getting your advanced transcog as well?
Yeah, that's an interesting question, because a couple of the rural generalists who are a year or two ahead of me that I always sort of looked up to from medical school days went and did advanced DipObs as well. So I wonder if I was sort of always heading there, but it certainly did help that I had a place that I wanted to work that needed those skills. It wasn't completely straightforward to go and do the diploma and then sort of land in a job that was set up. There wasn't really a streamlined job for me to come to, and I guess I always knew that there was a need for better maternity care here, but I've sort of had to forge my own path and job a little bit, which hasn't actually been that difficult, luckily. But yeah, I guess it was lucky that the need was sort of here, but I wonder, I'm not sure if I would have done it anyway, or where I would have ended up if I hadn't sort of come back here. So to answer your question, I don't know, maybe contributed to me coming back and doing it.
Thank you. I was mainly reflecting on, we talk a lot about our small communities, our rural communities are under-resourced in different areas, and needing to meet sort of the needs of the communities, and as well as providing the workforce where it's needed. And I'm sure Marco is going to talk a bit more about that later, but also knowing sort of the history of Nhulunbuy and Gove District Hospital, and the ups and downs that sort of come with having a rural generalist run hospital, and making sure that you've got provision of those services consistently and have that planning. And I don't know if Marco wants to comment about that, because I know you've had similar challenges around maintaining obstetric service, maintaining anaesthetic services at Gove District Hospital, and that's a lot of the medical administration stuff I guess you've been doing in making sure that's successful.
And I guess, yes, thank you for that. I that's a good example, Jasmine example on, and even though if not necessarily directly related, but is adapting your practice and expanding your practice based on community needs, and gaining skills that are adapted to the place where you're working and utilizing those skills to the fullest, or parking some skills for a little bit, like Jasmine has parked her emergency skills for a little bit, or general practice skills. She will regain those at any time, but at the moment, what she's finding a fulfillment from and what the community needs is obstetrics. So that's the beauty of rural generalism, that you can really reinvent yourself many times throughout your career and gain skills that are aligned to the needs of your communities, and your communities really appreciate that. What Sophie brings to the table in Gumbalanya, or what Jasmine brings to the table in Catherine, the community really appreciates that. They really appreciate that their doctor is constantly bettering themselves and constantly increasing their skills to provide care that is comprehensive, that is contemporary, but that is delivered at home. And that is a big responsibility, isn't it? We need to be the best that we can be. And the buck stops with us. There is no one else around. And the option is to jump on a plane and travel 600 kilometers away and be disconnected from your family, from your culture, from your home, from your support networks, to receive care by 20 or 30 different specialists that you don't know and you're never going to see again. And is that really the best care? And we've been led to believe that it is, because are you seeing the specialists or all the specialists for every single organ and all the problem that you may have? But most of our patients really want to have a doctor that they trust, that care for them as an individual, and that include all aspects of care to what they need. So to answer your question again, how do we maintain those services, those critical services? And to me, the answer is simple. You need to invest in training. You need to have succession planning. You need to have, it keeps you current as a senior doctor, because you're teaching and mentoring junior doctors and junior colleagues and students and so on. It also maintains a high level of excellence in the service that you're delivering. And then you have a constant pipeline of people that are coming and being exposed to and then shaping their careers. Sophie, again, great example. Sophie was the first 30 students that we ever had in Nhulunbuy. And look at where that landed us. So, I mean, I remember the dean at the time approached me and said, do you think you can host 30-year students as well? Because at the time we only had 4-year students of the Flinders program. And I said, yes, of course we can. And there was a lot of people that thought we couldn't. And then somehow said, yeah, we can do it, bring it on. And Sophie came along, and she was our little guinea pig on that time. And she needed a placement. We really thought that we had a lot to offer. And I hope that Sophie's medical training was actually enriched rather than disadvantaged by the time that she spent with us in Nhulunbuy as a 30-year student. Funnily enough, she came back as a 4-year, she came back as a resident, she came back as a registrar. And that was a very good example of investing in training to create your workforce. We have very strong connections with Royal Darwin Hospital for anesthetics training, and we have been training rural generalists and anesthetists every year for the last 15 years that then come to work in Gove. And the vast majority of them have stayed with us for a number of years. And then rural generalists are adventurous. We go looking for different horizons. We go looking for different skills. We go looking for different learnings from different connections with other places. And people come and go. And the only way to ensure that you always have a committed and a connected workforce is by investing in their training. And we're doing something similar now in obstetrics. We are going through a difficult patch where some of our obstetricians are retiring or have moved elsewhere. Some of them have moved overseas to do humanitarian work. And then our unit really stumbled, and there are not that many rural generalist obstetricians in Australia to just advertise and get someone to come. So we are investing in training them, and training doesn't have to be during traditional training pathway, you can do that after fellowship, like Jasmine did. Jasmine was a fully accomplished rural journalist when she decided to go and gain a different skill and reinvent her career. That was a great example of what rural journalism is all about.
Great, thank you very much. I knew Marco would add some words of wisdom to, to that. Thank you very much for sharing your story, Jasmine. Without further ado, I think I'm going to go over to Catherine, who's going to tell us all about working with a team within a department, I hope, servicing some of our much more remote communities across the Northern Territory, and the work that she does in that space and how she ended up there. Thank you, Catherine.
Okay, hopefully I've successfully shared my screen. So my name's Catherine, and it's nice. I know Jasmine and Sophie, and I've learned a lot about you, so that's that's lovely. I work as what's called a rural medical practitioner, which is something that doesn't exist outside the Territory. I suppose we're sort of GPs that work in remote clinics where there's no hospitals, and we sort of just do what we have to do. I got my FACRM in 2015, and I did my advanced skill in population health. And I've put a picture here of the lovely West Arnhem escarpment. And just to show you how beautiful a tip can be, that's an outlook of the Gunbalanya tip, because I've also done some work in Gunbalanya. But you wouldn't know it's the tip really if I didn't tell you. Hopefully I can get to the next slide. Oh, there we are. Okay, so this is just a little bit of a outline of me. So I grew up in regional Victoria, mostly in northeast Victoria, in a little bit in a different area where there was quite a high number of Indigenous kids at primary school with me. So, you know, I've always felt a little bit sort of interested in Indigenous health. And then I went to high school in this place called Mount Beauty in northeast Victoria. I've popped a little picture there for those of you who don't know where it is. And became the first student from Mount Beauty Secondary College to go and study medicine. So I went to Monash University from 2004 to 2008, and I did my third and fourth years and most of my fifth year in rural clinical schools, because I sort of didn't really belong in the city that much. It's nice to go there and go shopping, and then you leave, which is nice. So this picture at the top here is a view just near Mount Beauty, overlooking the high plains. And anyway, so part of me sort of belongs here, but part of me also doesn't belong here. So I went and did my internship in Bendigo, where I met my partner. He'll probably kill me if he knew I put that photo up, but it just probably shows that we're, you know, a little bit crazy, and maybe you need to be a little bit crazy to do the things that we do. I did my PGY 2 and 3 years at Royal Darwin Hospital, and I did something called a pre-vocational general practice placement program, which doesn't exist anymore, but is hopefully going to be revamped soon under a different name, where you can go and do a general practice placement in your hospital years. And basically I did this placement going out to the Tiwi Islands and some other islands, doing 3 days a week of clinical work with one of the GPs working for Top End Health Service at the time, and I loved it. I just said, this is what I'm going to do. I don't want to do anything else. This is what I want to do. So I started my ACRM training under the RBTS pathway, which is a different pathway to what a lot of people would do. And it meant that I could have continuity with the communities for the whole period of my registrar time. So I didn't have to do 6 monthly rotations or, you know, rotate every year or anything. And so I spent my time for all 3 years, I was going to Maningrida either 2 or 3 days a week. And then for 1 year, I was going to, 18 months, I used to go out to Nayu or Daly River 1 day a week. And then the rest of the time, I did a little bit of time going out to Bellewen as well. So I sort of developed this sort of long-standing sort of connection, I suppose, to Maningrida and the area around there. And so when I fellowed, I moved, I put a little map here for you, moved from Maningrida over to Ramingining and became the first resident RMP in Ramingining. There hadn't been a resident doctor there before. They'd had either locums or doctors fly in and out from Gove, which is just near Yirrkala over here. So I moved there as a sort of PGY 6 new fellow, you know, off by myself and sort of loved it. Eventually I took some time off from Ramingining and then ended up going back on a sort of part-time clinical basis. So I did some month-on-month off work in Gumbalanya, where Sophie currently is, and then also some month-on-month off work in Ramingining, again, which was lovely to go back there. I've also done a few other things. I've worked, because of the high rate of Hep B in Ramingining, we have about almost 70 patients with Hep B in Ramingining. So I sort of developed a sort of advanced skill in Hep B management. And so I'm involved with a Hep B project run out of Menzies School of Health Research. And I have done a bit of liver clinic outreach as well. And then I also work as a sexual assault medical officer out of SARC in Darwin. So I sort of do a few things. I also had a baby almost a year ago, so I haven't got back to doing all of those things since then, but we're doing a lot of them. Now, just to show you, there's this is Carhill's Crossing across to Gumbalanya, and quite a common occurrence of cars being swept off the edge, and it's also an incredibly high number of crocodiles just there, so it always gets the media attention. And then up the top here, I've got the road to Ramingining, which you'll see is a little bit like a river. And looking there, you might think that's the road going off to the left, but no, this is the road continuing around to the right. So it's a very adventurous place to go. And we moved there a few weeks after a Category 4 cyclone had gone over the top. So it was very, very wet. So I moved to Ramingining. We had about 1,000 patients, 4 nurses, 1 AHP and me. I've put GP in little things there because, you know, GP is an interesting word, and probably Marco would argue we call that a rural generalist. There's, you know, when I was doing my training, there wasn't a pathway to do that, but I suppose what I wanted to do was I wanted to be a remote doctor. So that's what I've become. So this is the airport in Ramingining. Here, and then this is after the cyclone that, you know, most trees in the community had blown over, so there was very little shade and it was quite hot. This is what we hope doesn't happen very often, a bit of car accident. And I don't know if any of you have seen Black As, the series on ABC, but Ramingining is the home of Black As. So this is the Black As guys. They've got Joe, who was working as our driver while we were filming this, and Chico, who was working as a driver with us and then trained as a health worker. So he's now a health worker in Ramingining. We've also got some of the art projects that the community has done. This has been displayed at the National Gallery of Victoria. And you definitely get to know a lot of really amazing artists during your time working remote. And then to the right, I've got some of the living conditions that you'll see, you know, a lot of people would live, you know, in conditions like this. So you're sort of dealing with some pretty big disparities in terms of people's health needs. I suppose, why would you go somewhere like that? I've just put a few pictures. In fact, I should look at my notes as well. I've got a picture here of, this is my partner, Jamie, and it's just on this little sandy bit near the mangroves, cooking some damper in the fire, and it's just sort of serene and pristine, and you just feel like you belong, you know. I've also got here this picture of the floodplains, and, you know, you can go for a walk after work and just go and look at the floodplains and, you know, listen to the birds, and it's just very relaxing. This is a little waterfall between Maningrida and Ramingining, near the homelands along the road between Maningrida and Ramingining. There's no crocodiles there because it's so shallow, so I feel safe to get in the water there. And it, you know, it's a pretty unique environment. I've also got a picture of my veggie garden in my backyard there. So, you know, you can achieve lots of things with a lot of buffalo poo and a bit of compost. So also, I've got a picture of one of our local artists here, and you're just looking after these people that are in their 80s that have just had the most amazing lives. You know, there's one of the guys out there that, you know, can tell you about when he was a kid and there was the bombing of Milingimbi, and that was when there was the bombing of Darwin, and he remembers that. You know, he's got these amazing stories, and they can tell you amazing stories of basically, you know, before they really knew white people. You know, they were growing up with their parents on country, and, you know, they're trying to pass on a lot of that history to their grandchildren and their great grandchildren. Also, some little other stories of what you get involved in. there's no vet, you're the local doctor. People turn up with various things like 250-gram wallabies for you to look after, and things like that. And I think, Marco, did these two make it to your house eventually, where your wife looks after some wildlife as well?
They did.
I think they did. Yeah, yeah.
They did.
So this is Loppy and Ruby, were their names, and then this is Max here.
That's good.
So
Continuation of care.
Yeah, continuation of care. So we would look after various things until we could get them out to a wildlife carer, because you're the person that can just look after everything. And other things like, once this poor dog got hit accidentally with an axe, and so they turn up, can you please suture up my dog's head, go and have a look, and there's the skull and the gaping wound from the axe. Look after the dog, build some relationships in the community, and then a few months later, you're looking after the owner of the dog and diagnose them with leprosy. And they're, feeling very stigmatized by the diagnosis, and they won't speak to any of the health workers or the Aboriginal staff in the clinic because they're feeling so stigmatized, but they trust you because you sutured up their dog's head, and you get them, on treatment. And I think it just goes to show how you can really build relationships and get things done by doing a few extracurricular activities. And as long as, Marco, you don't ask where the suture material came from, then that's fine. Marco was my boss while I was working out there. So I'm trying to think what, the other sort of things that draw you out there, that you feel just appreciated. They really appreciate your spending time away from your family to be there, and they really understand the connection to family because they feel really strongly connected to your family. Sorry, to their own families. And so they understand you living a long way from your family is a really big deal. And they understand sometimes you need to go back and visit your family, you need holidays, you need to get away, but they just really appreciate you being there. And I think the other thing you can do is sort of really advocate for your patients in a system that can be very chaotic, and you sort of feel can be very satisfying that, knowing that you've got a good outcome for a patient, and you've sort of, despite all the Swiss cheese that gets in the way, you've got through the Swiss cheese and the patient's doing well. Yeah, so and I sort of worked for 8 years or so within that West Arnhem region, or the very sort of west side of East Arnhem. And so you get to know a lot of families, and you might find that there's really only 1 or 2 degrees of separation between you and any patient that you might come across. And there were a lot of kids that I'd looked after when I was a registrar in Maningrida, with either congenital heart disease or, one had gastroschisis, where, I would then still see them when I was in Ramingining because they were from the homelands on that side of town. And then so they knew I was in Ramingining, and they'd, happily come and see me there. And so you're seeing kids running around that are sort of getting pretty grown up, where, you looked after them when they were just coming home from the Royal Children's Hospital having had, major surgery. It's pretty satisfying. I suppose the other really satisfying thing is looking after people right from the start to the end of their lives. So whether it's looking after a clan leader when they're dying, and going through that sort of palliative care process and seeing all the ceremony and the rituals and the traditions that are happening, and you're welcomed into the sort of the room to look after the person while all that's happening. So you can just sort of really feel the history that's going on as that person's passing away, and that the next clan leader is sort of taking over. And I suppose on the other end, also being around when babies are born. We try not to have babies in Ramingining, but sometimes we did. And everything in between. I'm trying to think, what have I'll also comment a bit on the population health special skill. So a lot of people would see rural generalists as having a real clinical special skill, so it's emergency anaesthetics or obstetrics or something like that. But I just really felt like population health, for me to do my population health special skill, I could continue with my time in Maningrida. And so I did mine based around acute rheumatic fever and rheumatic heart disease in Maningrida. But I also felt that that was really probably a good choice in terms of the knowledge that I needed for my career. There's no use having a GP obstetrics or GP anaesthetic sort of qualification if you're hundreds of kilometres from a hospital. I really needed to get the skills that would suit, the communities that I wanted to work in. And I think it really did prove very useful. Like I don't know if, people might not know a lot about the region, but lead So lead shot is still being used quite widely in communities, and it came up as an issue in the community, and lead shot is still sold in the shop. And, you know, people have been trying to change that for a very long time, but by approaching the elders that I knew were on the board of the shop and raising that as an issue, I was hoping to just stop lead shot being sold in Ramingining, but the influence of those board members meant that all through the shops in East Arnhem Land, they stopped selling lead shot. You know, so just something like that has a massive sort of impact on the future of, you know, children's development. And I think it really was really satisfying because there'd been lots of other people trying to achieve that, but by just chipping away on the ground and, you know, working with the people that I knew were in the right positions, we actually managed to get there without that much effort, you know. I'll go to the next. There's always a good buffalo story when you're in the NT. So some challenges. I've put this photo here. This is a photo of the shop in Ramingining on grand final day, not the AFL grand final in Melbourne, the AFL grand final in Ramingining. And, you know, the queue was an hour and a half long to get your groceries. That's not very normal, but, you know, some people's supplies can feel like an issue. We're vegetarian and we didn't feel it. We actually felt the fruit and veggies were really good. We got a weekly delivery on the barge that came to the shop, and we just go shopping on barge day. But for some people, you know, access to supplies, there's not the sort of Coles you can nip round the corner. It's a little bit more difficult. Unlike Sophie, who didn't kill the file snake, I did kill that python because it killed one of my chickens. There is a little bit of wildlife that sometimes gets in the way. This photo at the top of the right is the backyard of my house, where at 6 o'clock in the morning there was a grand kerfuffle, and I looked out the window and there's a buffalo that had been herded in there by the camp dogs. And subsequently took us about an hour and a half to get it out of the backyard, where it then decided to run through the fence, not through the gate, taking the fence out, and then was eventually shot by the police. So, you know, you have little adventures that wouldn't happen other places. I was a little bit late to work that day because we had some things to sort out. The bottom right here, I've got this picture. This is basically sort of worldly possessions packed up. You know, you do have to pack up and move around. And, you know, it's not always convenient, but, you know, the benefits you get of, I suppose, putting yourself out there and going somewhere to have an adventure is, you wouldn't regret it, I don't think. And this is me doing a liver clinic visit to Borroloola, so that's not actually a Ramingining photo, but that sometimes things don't go to plan, and you can have spontaneous things that come across, and we were all fine. The oxygen masks were put on and we didn't actually decompress, but, you know, everything always, there's a challenge along the way. So whether that's car problems, which is much more likely, plane problems, you know, everything in between. What's happening in the future? It's a good question. At the minute, since I've come back to work in April, I've been doing mostly medical education, which is something I can do at the minute with a young child. That said, I really like doing the liver clinic stuff. I'd like to keep doing that. I'd really like to do some more SARC work. I don't know how you fit it in. I would also like to do another extended skill at some stage. So I was interested to hear your story, Jasmine. I really, you know, like to do a more clinical extended skill to go with my public health skill, but I don't know how to fit that in. I'd like to have some work-life balance. I'd really like to maintain my connections with sort of West Arnhem and West and East Arnhem. My husband speaks Jabapoingu, and I just speak a little bit, but he's quite fluent, and I'd really like to work on my language skills. But I'm just not very good at that, and many more things. So I don't really know where I'll end up, but I will hopefully be doing a combination of those.
Thank you very much, Catherine. I'll just unshare your screen. Excellent. Wow, that was quite a story. I feel like everything you said just made me think of experiences that I've had in my time living and working in rural and remote communities across the NT. the family stories, the connecting with patients, the learning about communities, engagement and love and passion for the animals that they have. I'm sure all of us have already accrued many treating of animals in community stories that we could probably write a book about, I reckon.
Unfortunately, the joeys needed to be fed like twice overnight. It was pretty hefty work, and there's no maternity leave for a joey.
No. One thing I did reflect on that I might share is how much treating animals in community really helped me to understand the community that I was living in and the people I was working with. And when I was living and working on Elcho Island in Gullawinkle community, there was an incident where a cat had been mauled by a pack of dogs and wasn't going to make it. But the cat was owned by an elderly gentleman in community who was end-stage renal failure on hemodialysis. But the process of talking about how we were going to manage the cat involved family meetings, sitting down together, deciding on euthanasia, who was going to be there. Don't ask where the euthanasia drugs came from either, Marco.
I've been
they were via the vet.
We had a dog that was paralysed after being hit by a car, and the same thing. Like, can you send the dog to Darwin to hospital? It's like, well, even if we got the dog to Darwin, I don't think they're going to fix the paralysis and the spinal cord injury. It's thankfully, though, the vet was there the following week. It was like one visit every 3 months, and that happened to be the following week.
Yes, unfortunately, this cat with its open bowel was probably not going to make it to the next week. But but just the sitting down with family and understanding how animals play a huge part in the kinship.
Well, and you know, they've all got their skin name, and people will tell you your relationship name based on your own, you know, my skin name, and then the dog, and so you know, how your siblings or your father or, you know, something like that, they're valued as children.
So there's some really great lessons, and I also learned a lot about how funeral business was managed and negotiated in the context of Bunguljama for this poor little kitten that had to be put down. So yes, those stories really enrich our experiences of our communities and the culture as well, and I think they shouldn't be underestimated as a really core part of how we become immersed in you know, being part of the communities that we work in. I'm conscious of time and I really want to go back to Marco, even though I've got hundreds more questions I would love to ask all of you. But I'm going to go back to Marco to tell us about the pathway and how we get there and what's next. Thanks, Marco.
So just before I start, I Kat, don't worry about it. I know where the suture material come from. I done enough suturing of dogs myself to know exactly where to get it from, and I relate to that. You become more than only the doctor. You are the vet. You are an allied health specialist in many areas, and do some physio and do some splints as an occupational therapist, and provide dietetic advice and provide financial planning advice to some of your patients, and some other things that are not services available there, and you as a doctor are seen as a source of knowledge and advice. So our role in community sort of goes a little bit beyond the expectation of what you would expect normally. And then that touching base again on that role of being a community member, to me has always been very special, but it's difficult. Not everyone does that well. I mean, how do you play sports with your patients and go to a barbecue and drink with them, or your kids go to school together, or your kids play sports, or I coach some of the kids in the local soccer club, or my wife is a coach in the BMX or the swimming instructor and so on, and you being a very, very active community member, and you are visible and you're there and you are constantly in the public eye. And I consult in barbecue and I consult in the second aisle of Woolies, and I consult at the golf club, and I consult everywhere. And how do you manage that and keep a life balance and keep the boundaries? It's a bit of an art in rural medicine. That to me is what makes it interesting. The other thing I was going to touch base on is talking about people that inspire you. And I think the stories of all of you, including yours, Olivia, are super inspiring. And Kat, when we worked together, I was absolutely blown away and inspired of what Kat was offering to Ramingin community, something that Ramingin community never had. A resident doctor that was as committed as Kat was, as well trained and as passionate as she was, and with language, with community involvement, with her public health skills, with her hepatitis B and her SARC skills, and how she was made it her business to always better herself to make sure that the community was getting the most they could out of her, and the work ethic. It was something that was extremely inspiring, and that to me is what a rural generalist is all about. And yes, I was going to point out before when Olivia did the introductions, I'm a rural generalist. Jasmine is a GP obstetrician. Sophie is an ACROM trainee, and Kat is a rural GP. The reality is we're all rural generalists, and we're always on a training journey. And the journey is not it doesn't have a beginning and an end. It's a very long journey that continues even after fellowship. And Jasmine has a good example of how that looks like, and where you go and gain different skills. So, talking a little bit more about the pathway. So this has been set up as a project in the NT, funded by the federal government, to establish a coordination unit. And the idea is, and I'll show you in a second why, is to try to be the glue that puts together every single organization that plays a part in training a rural generalist. And I couldn't, unfortunately, add to my presentation today a little diagram of what the pathway looks like. But then we also have on that diagram who plays and who coordinates and who manages that space. So in recognition of that, then the federal government said, well, the best way to establish a national pathway is to actually have coordination units that join together medical schools, health services that offer pre-vocational years and expand pre-vocational training into the into rural generalist journey and go primary care and go out to remote communities as a junior doctor, as an intern, and how important that is. And Sophie, again, great example of why, and Kat and Jasmine are also living examples of how important it is to expose junior doctors early in their career to what rural medicine is all about. But then it's very important for them to see a career ahead. If it's only an adventure and so on, well, where is it, your career fulfillment? And I think that's where it's been very important that ACROM and RSCGP and the World Summit of Rural Generalism and the government has put all that effort in raising the profile of rural journalism as a specialty, recognized it and rewarded and respected as such, and making sure that you're not missing out by becoming a rural generalist. You're not missing out in being involved in academia. You're not missing out in being involved in research. You're not missing out on getting involved in policy development. You're not missing out on expanding your clinical skills as much as you can. Because we want to establish the pathway in the territory in a way that is adapted to the very specific needs of the territory, we also assemble a reference committee with all our key stakeholders actively involved throughout the journey of what we're doing and how we are developing the pathway in the NT. And we developed that governance structure where there is a steering committee that is advised by this reference group, where Flinders plays a part, with the colleges plays a part, with the Aboriginal Medical Services play a part, with registrars and trainees provide advice, with the health services in Top End and in Central Australia play a part. And we have national involvement of the colleges and national involvement of the Rural Doctors Association and the Rural Health Commissioner, etc., that are providing and informing that our pathway is aligned with the national strategy, but is also adapted to the reality in the territory. So at the moment, this is the coordination unit, is me as director, and I report to the deputy CEO of the department, and I got the full delegation on this project, reporting also directly to the Commonwealth. And then we got a senior project officer, which is Vidula, some of you might have known, who is currently going to take a bit of a more senior role in this to raise the profile again of our unit. And we have assembled a small team, and we're trying to take advantage of existing functions so we don't have to duplicate for marketing, for a promotion, for career navigation, career support, and managing and assisting trainees in the process. this is an example of who is involved in rural generalist training in the NT. We have the health services, we have the Aboriginal medical services, we got the colleges, we got Flinders in the training hub, but we also have the medical program. We have our regional training organization, but we also have our VTS who offer training in the territory. We have the health, the PHN as the regional or rural workforce agency, but also as the branch of the federal government in the support of primary care. We got the Postgraduate Medical Council, now called PIMAS, that also provides accreditation to pre-vocational rotations. And we want to expand those pre-vocational exposures to more interns and more residents to be exposed to rural generalism. And at this point in time, we only do it in hospital. And as Sophie said, well, that's only a small proportion of what rural generalists are, and a very needed proportion of rural generalists are there, but the majority of rural generalists are needed in the community setting, and that's where we want interns, that's where we want junior doctors to go and experience that firsthand and contribute to those communities' health services. And we also want to support doctors like Kat or like Sophie that are living in these communities to have more medical colleagues joining the ranks and get them involved in mentoring and training and supporting junior colleagues in their journey. So it is a big heterogeneous group that are involved in different parts of the training, and we're trying to be the glue that pulls it all together and provide a continuum in the training journey from, again, medical student years throughout until fellowship and beyond, and making sure that we expand opportunities. So we have a big project plan, and these are the things that we are sort of concentrated at the moment. And one thing that is very important for me is to create models of care and industrial pathways and clinical governance that will cater for rural generalists. So people like Jasmine or like me, when I came as a GP surgeon, don't have to create your own job. Actually, you do, and that's the beauty of rural generalism. But how do we support for you to do that better? How do you establish a GP surgeon service in Nhulunbuy? How do you reestablish a rural generalist obstetrician-led service in Catherine? How do you use your population skills to the fullest when you're living in Ramingining or in Gumbalanya? How do you apply mental health skills if you have an advanced skill in that area, that you are credentialed, that you have a scope of practice, that you have a full recognition of those skills? I remember Kat back in the day telling me, look, I got all these skills and I can't use them. And how is it that I cannot put to the benefit of my community, my population health skills, because I'm not involved in policy development, I'm not involved in service delivery planning, I'm not involved in these things? And how do we create those opportunities for our rural generalists? How do we make sure that they see a clear journey? It's a very convoluted journey. We are living examples of it. The 5 or 6 of us in this panel navigated this pathway very differently and got to a very different endpoint and practiced very differently as well. And that might be a bit off-putting for some of our junior doctors that don't see a clear pathway ahead of them or see barriers along the way. And we want to make sure that it's a clear pathway, not only for training, but also for employment, and then for to be able to fully contribute to improving the health of, in our case, people living outside the big cities. In the territory, that's 40% of people. 100,000 people live outside Darwin and Alice Springs. And outside of Darwin and Alice Springs, there is only 1 doctor per 1,000 people, which is 3 times less than national average. The national average is 4 doctors per 1,000 people. And in rural and remote NT, well, the number is 1 per 1,000. And that's an average. Many communities have less than that, way less than that. And how do we address that? That maldistribution of medical workforce that not only require training more doctors, also require advocating, creating positions, creating training pathways, creating employment opportunities, in getting involved in the models of care, getting involved in a way to make sure that we can offer more closer to home. It is very important to our patients. They appreciate that greatly. That we take that responsibility to learn about hepatitis B, because that is a great need in the community, and that we become an NT expert in hepatitis B, like Kat has become, and a point of reference to manage hepatitis B in community. And that's not to substitute the role of the infectious disease specialist. That is to enhance that and to work in partnership with, to offer that service as part of your primary care provision. So it is, how do we do that safely? How do we partner up with our specialist colleagues to make sure that we are taking full advantage of our own skills to apply that knowledge in context? So that's some of the work that we're trying to do in the coordination unit, is keeping an eye in the long term and having a clear vision. Yes, we are creating a training pathway. Yes, we are reviving the PGPP program, and we are increasing training opportunities, but we also need to make sure that we do that in a way that we inform workforce planning, that we strengthen clinical governance and strengthen the profile of rural generalists as specialists of our own rights. How do we influence models of care to provide better care to our communities, but also to ensure that our rural generalists can practice to the full breadth and depth of their scope? And how do we make sure that our industrial pathways that are robust enough to ensure that our rural generalists are remunerated accordingly? And there is discrepancies in whether you work in private, whether you work in the Aboriginal medical service, or whether you work for government, if you work in hospitals versus not. I think we need to create better industrial pathways as well, and we're doing some of that work. So that's what we are doing. We are sort of chipping along aligned to the project specific deliverables, but we also are keeping a very close eye and managing the long-term view and addressing all these matters. So what are our goals? Our goals are to develop a training and employment pathways that are tailored to the needs of the ENT communities, which is different to the Queensland model, which is not rural generalists based in hospitals. And maybe we need to all start embracing the term rural generalists a bit more broadly to make sure that we all undoubtedly recognize that Kat and Sophie and Olivia, when she used to work in NMLAN and when she goes back to remote, and Jasmine and myself, we are all rural generalists, even though we might not have a hospital presence, might not do obstetrics, might not do anesthetics. I think it's important to raise the profile of rural generalism altogether, to make sure that we are measured against the same standards that any other specialty are, and we are as accountable and as transparent and as contemporary and as committed to excellence as any other specialty is, and therefore as influential as other specialties are in informing policy, resource distribution, and making sure that our health departments are hearing our voices loud and clearly. But we need to sort of earn some of that space there. We want to really explore alternative models of care. We think that we can offer more to our communities, and we can increase our profile in the delivery of comprehensive primary healthcare services, but we must have a very strong public health hat. We must offer emergency and acute care, and we need to be agile to learn and all the skills, or to connect our patients with other skills without the patient having to leave their communities, their families, and their homes. And so influencing models of care is something that I feel very passionate about. And we need to train more doctors who understand the NT context and that are equipped to deliver contemporary medical care in these remote communities that is patient-centered and culturally appropriate. It is very difficult to bring someone trained elsewhere and then trying to retrain and relearn all this knowledge and all those skills. So growing our own, I think, is the solution, and it's definitely the way to do it. And we all have a role to play there as mentors and supervisors and as educators, but also as colleagues, as supporting our younger colleagues and inspire them and ensuring that we help them navigate this exciting career that is rural generalist medicine, and show them how different it can be. Look how different our careers are, and yet we have a lot more in common than things that are different about the way we practice medicine. And I think, as we were saying, we are all very passionate, and that might lead to conflict, and that might lead to issues, and that passion must remain. And that passion is shared by our nursing colleagues, and that passion is shared by our community leaders. And how do we channel that passion to bring rural medicine into the contemporary picture of what medicine is about today, what the standards are, what the expectations are from communities, from colleges, from APRA, from the AMC, from the government, etc. We can definitely do that. So that's our aspiration, and that's what we envisage. And we're very confident that we can do that. The territory has been doing this for a long time. We are not starting from the scratch. On the contrary, we have a lot of the pathways already been cemented by people before me, and we are all results of this pathway. I would like to offer a clear pathway, because our pathways, as you described, all of you, were a bit convoluted, and we have to invent our own. We were very motivated and very driven to do so, and I think we need to make it easier for our junior colleagues and our medical students to see a clear pathway for themselves. So yeah, I'll happily just leave it there and open the room for question and discussion.
Great. Thank you, Marco. That was really interesting and really good to hear what the vision is for rural generalist training and pathways, clearer and equitable pathways that meet community and workforce needs as well in the Northern Territory. I'm really excited about the future of rural generalism in the NT, especially under your stewardship, Marco, but also just from hearing the stories from Sophia, Jasmine and Catherine, and the numerous other stories I know of other rural generalists who are out there delivering well-needed services to communities in the Northern Territory. I would like to open for any questions from our very knowledgeable group, if they have any questions for Marco on the information he's just presented. Oh, that's fine. Sounds like you
no,
were...
I was going to say, Marco,
sorry, Catherine.
If you could very briefly outline, how will this generalist pathway be different from, say, the ACRM pathway that a lot of us might have done, or say an RACGP pathway with a FAR GP? Very quickly, what's the difference in the training pathway?
Look, there is no difference. The vocational training pathway is exactly the same. You do your ACRM fellowship in exactly the same way that you would. You have more funded training time in recognition that you might want to spend more time gaining broader skills, and in order to be able to come to your communities with more tools in your bag and being able to then grow from there. But the training requirements are exactly the same. The main idea of the pathway is to connect the medical school with the pre-vocational years and the vocational training on the one roof, and making sure that if you know when you finish medical school or during your medical school years that you want to become a rural generalist, that we have seamless rotations for you to gain all the competencies you need to gain and meet all the training requirements that you need to meet during your internship, during your residency years.
So you'll be able to get your anesthetics rotation easily.
Exactly right.
Yeah,
exactly right. You will we have what we call streams during your pre-vocational rotations that are tailor-made to meet all the training requirements for rural generalists. In this case, a FACRM or an FRSCGP with a FAR GP. So the requirements are very similar, and then that.
But there's no sort of end date set there for you. Like you don't have to do your exams and you're kicked out of the system after 3 or 4 years. Yeah.
Correct, which was a big problem for us in the past. Many of our registrars were coming to me and saying, well, I've done my years and I finished my training and I got my college requirements, but I don't feel that I got the skills to work as an independent senior doctor and supervise and manage patients independently and go and work on my own. And there is no way to transition from fellowship into a senior role. And some people are different. Some people recognize that early on and drive their career towards that. But we were getting many people that sign into the training program very early and then run out of training time. At the moment, under the AGPT program, if you tick the box that you want to be a rural generalist, that immediately extends your training time from 4 to 6 years. So you already have extra 2 years of funding to be on the program training. The ACRM independent pathway remains alive as an option. There is going to be another program called the RG100s that are going to be run by ACRM, which is a funded program, very similar to independent pathway, but with funding for you to navigate your training. Again, there is no time cap to that. And there is the RVTS, as you were mentioned, as an alternative model, which is, again, the college requirements are exactly the same. ACRM and RSCGP remain the peak bodies for setting the standards of training and the standards of to achieve fellowship, and we're not going to change that. What we will try to do is trying to make sure that we offer broad training opportunities for people navigate those pre-vocational and vocational years to gain those skills and to allow a seamless transition from being a registrar to being an independent practitioner. How do we bridge that? Because at the moment there is a big gap. We're seeing a big gap, particularly people that navigate the training very quickly. They enter the training program at PGY 2 or 3, and they finish on the PGY 6, and suddenly they've been working 38 hours a week, and suddenly they feel, well, I need to gain more experience, I need to gain more knowledge, I need to get more confidence, and how do we do that? So the idea of the pathway is to offer a seamless a way to gain all those skills over a period of time, and to make sure that we have visibility and we can help people navigate that pathway through career navigators and offering pastoral care, not only in the GP training side of things, but also in the pre-vocational space, and making sure that medical students have a pathway in front of them that they know that they can navigate.
And I imagine that pathway is going to be flexible enough for people to jump on and do various things at various times that they need to upskill, gain experience, meet the mentors and people that inspire them along the way as well, and to change your ASTs or add another one if you so choose to, in a much more easy way than having to negotiate your own pathway back into the hospital system to get another hospital-based skill, or vice versa into the other avenues as well.
Absolutely. So we're very strong about having flexible entry into the pathway. So you can choose to enter the pathway from medical school and get your internship and resident rotations guarantee, and therefore a seamless transition into vocational training and navigate that pathway. But we also recognize that some people might make that choice later on, and we want people to explore and see other things, and we want to offer opportunities for people to be exposed to rural generalism at different stages of their career. And then they might choose to join the pathway at different stages. You can join at a vocational level. You can get a lot of RPL and join in towards the end of vocational training, or you can join it from the beginning. And I think that flexibility is key, and for those that know me, I'm a strong supporter of flexible training and flexible employment and things that are tailored to meet individuals' needs, because that translates into people that are happier with their career, have a better work-life balance, have a better fulfillment with what they're doing, and they tend to offer more and to commit more to their careers, and that only enriches the profession. So flexibility in training, certainly, flexibility on employment, absolutely, and making sure that there is not a one-size-fits-all, which makes the pathway more confusing to navigate, by the way, because you can navigate it in many different ways. But that's our job to do, and we will take that role and that responsibility to navigate the pathway on the behalf of our trainees, and making sure that we have a skeleton pathway that is common for everyone, but that pathway can be navigated in many different ways to meet the needs of our trainees and to meet the needs of our communities as well.
Thank you, Marco. I'm going to bring our webinar to a close now. I promised I'd end on time, and we're running 15 minutes over. So I feel like this conversation could go on for many more hours and be just as enriching as it has been so far. But I'd like to formally thank Dr. Marco Brasino and the Rural Generalist Coordination Unit, part of the NT Department of Health, for coming along and sharing all of the things that are happening in that space, plus your personal experiences and passion for rural generalism, and training lots of people in this webinar at the moment and being responsible for some of our passion in being the types of doctors that we all are. Thank you, Sophie, for sharing your experiences as well, and I wish you all the best with the rest of your fellowship training, and I hope you find what it is that you ultimately want to be, and if you don't, I'm sure you're going to have some wonderful experiences along the way and try lots of different things. And Jasmine, thank you also, and please keep up the good work in maternal health services in Katherine. I'm sure the community and your peers really appreciate your contribution to health service provision in the Katherine region. And Catherine, I wish we had more time to talk to you about the public health stuff you've done, especially around hepatitis B, but that will have to be another webinar, I think. So you might all get invitations back to tell us more about your journeys sooner or later. So thank you very much, everybody. We are going to end this broadcast now, which will cut all of you off. I apologise, we won't have time to chat afterwards, but sincerely, thank you so much for participating. I'm sure everybody who watches this after is going to really be inspired as well to embark on journeys that they may not have thought of before. So thank you very much.